102.5 FM, KXSFLP San Francisco, and KXSF.FM.
You're tuned in to Spark, informing minds, inspiring ideas, igniting innovation. Let the conversation sink into your soul.
This is Kelly Marlowe, host of Spark. Today I'm talking with Dr. Sasha Bystritsky, professor and director of UCLA's Anxiety Disorder Program. He's also the founder of Brainsonix. We will be talking about anxiety disorder and how you can deal with it. Also, we will be discussing his Brainsonix innovation that has woken people out of their coma and other possible disorders with this device. Thank you for joining me today, Dr. Bystritsky. What is the most common psychological disorder today?
Well, anxiety disorders as a group is most common psychological disorder. And among those, most common is actually social anxiety disorder. But very frequently, anxiety disorders overlap. They come in bunch. People have different variety of anxiety disorders in the same people.
So anxiety disorder is the most common. How would you define or describe an anxiety disorder?
Well, anxiety disorder, it's people who really have a lot of fear. Most commonly, it's a fear-based disorder, and it could come from some specific fears like simple phobias, or it come from fears of their internal sensations like in panic disorder, or it comes from fear of uncontrollable worry in generalized anxiety, or some other fears like from traumatic episode like in post-traumatic stress disorder.
So there's social, and then there's phobias, and then generalized, and PTSD. Are there any other?
There are many groups.
Many groups.
And that's why it is one of the most common disorders in mental health. It's 1 out of 3 people in the United States have lifetime occurrence of anxiety disorder, so it's very, very common. I usually would like not to go just by the labeling people with the disorder. I'm trying to understand dynamic interaction between different components of anxiety disorder that forms a picture.
Well, 1 out of 3 people is a lot. That's a third. So it sounds like generalized. Would that be the category that applies to more people then?
The most common is social anxiety. We're all fearful of other people judging us, but some people go far beyond that. Generalized anxiety disorders is also very common, and it's mostly people who worry about almost everything. It's people who worry about their health, finances, different occurrences in their life. It's also extremely prevalent. Probably roughly around 5.5 or 6% of population have that.
So can you describe, we should probably start with social since that's the most prevalent. What is a social anxiety disorder? And then maybe we can go down the line and talk about the differences between each of them, the phobias, and then generalized and the PTSD and the treatment options for them. But first, I'd love to understand, for example, for social, what are the symptoms? Like how would one know he or she has a social anxiety disorder?
Well, let me tell you first two things. One, I usually do not try to fit people into categories. As I said, some people meet many or a few of anxiety disorders. I'm more trying to understand from the position of what we call ABC anxiety, where A is for alarm. It's almost like a car alarm. It has in all of us installed by the nature. It's a rapid response system, physiological and psychological. And then we have the second system, which is belief. It's more complicated. It's our reality. It's what we remember. And access to those beliefs is sometimes compromised by anxiety, and we get stuck in false beliefs, catastrophic beliefs. And the third thing is coping strategy, is that's for C. People cope with anxiety in a certain way that sometimes seems to be good, but then it maintains anxiety. So if we're talking about social anxiety disorder, let me give you an example. Let's say a person who is going to present something, who he afraid will be judging him. And sometimes in generalized social anxiety disorder or generalized social phobia, people are afraid of almost any social interaction. So this person would go, say, on the podium, and suddenly they feel that they're sweating profusely, and that's their alarm. Their heart is palpitating. They feel dizzy, nauseous. And then they start worrying about their performance. This is B. They access the beliefs, and mostly catastrophic beliefs. People will judge me. I'm going to fail right now. I would not be able to present well. So they worry about that. And sometimes coping is they start making pauses, and sometimes they even could leave the podium. And that would be, or they will feel that people could see them sweating, and they would sometimes interrupt their speech and just leave, and then next time it's going to be even more difficult to give a speech. So that is one of the examples. But again, each of these disorders is extremely complicated. For example, there are people who are impaired. For example, I had a patient that would come into, it's a male, come into bathroom, and then they afraid to pee because other people would hear their urination and they will judge them, or they will be embarrassed about that, and then they become avoidant of that. And social anxiety is very big on avoidance. That's the main coping strategy. I have to avoid that. And sometimes this particular person could not come to any meetings because they would be afraid of this anxiety repeating itself, and they would avoid all the public bathrooms, and you have to sometimes go when you have to go. So, and more than that, when you're anxious, you sometimes have to go more often. So he was locked in this vicious cycle of having anxiety and then needing to run for the bathroom, and then unable to go into the bathroom because other people will be there, and he started to avoid a lot of meetings, and it significantly impairs people's performance.
So how would you treat it?
Well, usually main two treatments that being employed are behavioral therapy and medication. And they have proven to be almost equal for these disorders and have their pluses and minuses. Medication could work faster, but may not give the same permanent relief as behavioral therapy. Sometimes it's good to employ both of them in tandem. How I can give you an example. When people come into our clinic in UCLA Anxiety Disorders program, we first explain to them why they're having anxiety and what maintains them, and we talk about this ABC anxiety theory. We explain to them and ask them to monitor their alarms, their beliefs or their thoughts that occur in their mind, and what do they do to deal with the anxiety. And sometimes what they do is that maintains anxiety, because you escape and you have immediate relief, but next time it's much more difficult to come into the situation. So we explain that. And then what we do, we expose people to the situations that trigger those anxieties. We expose gradually. We teach them some techniques that could reduce overall level of anxiety. For example, teach them relaxation, meditation, strategies that they could do outside of the situation. But then we really creating something that we call hierarchy of fears. And that would be we're rating fears from 1 to 10 or from 1 to 100 and create several situations that would frighten this person. And then would be we would expose them to kind of medium level, and then try to increase the level of situation, level of trigger that causes the fear, and slowly prevent people to avoid this kind of situation. And very interesting, we're not just targeting anxiety and decrease of anxiety, we're also targeting change in beliefs, because people predict that one thing will happen. And in reality, if they stay in the situation, deal with their anxiety and kind of focus on performance, or say on the speech, instead of focusing on how anxious they are, the anxiety will be there, but it will become not very important. And they would be able to stay, and next time it will be easier to go into the same situation, next time even more easy. Now, some people would not be able to handle that, and because their anxiety is too high. You see, in ABC theories, all these circuits that drive alarm, we have alarm circuits, those who have access to our internal reality, to our beliefs, and those who determine our coping, they all interrelated. Brain responds as a whole. And sometimes we just resort to avoidance. If we start running in coping, all the energy, all the blood supply goes to the coping, and we may be decreasing our anxiety alarm, but we basically incorporate the belief that the next time this situation is more dangerous, and next time people go into the same situation, they have much more anxiety, and that's how they maintain it over time. So we sometimes give people medications to reduce anxiety, and we mostly give the medications called antidepressants. They also help with anxiety, and also help accessing more positive beliefs. So people become more willing to stay in the situation. They become more willing to challenge. And it requires a lot of courage to challenge those situations.
So I was about to ask you, which drugs do you usually pair to dial down the anxiety? What's the most common that's used for in these situations?
The most common medication that is used for anxiety right now is serotonin reuptake inhibitors. They, as a group, the most common and probably the most effective. In anxiety disorders, they produce about 60 to 70% of relief. And in some people, they completely block anxiety, and they could go and just have temporary treatment with this, and they recover. And in some people, in majority people still need some form of behavioral therapy or instruction from their physician to go into the situation, challenge yourself, and also perform some anxiety-reducing strategies, speaking to someone more rationally in regular therapy, or doing behavioral therapy by a specialist.
So the most effective therapy is really to dial it down with medication physiologically, and then with behavioral, where you try to turn down the stimulant in showing them that they can actually handle it, and that it's a false belief. Is that correct?
Right. It's learning new coping strategies.
Learning new coping strategies. What about phobias? What are the most common phobias?
Well, as I said, the most common phobia is a social anxiety disorder or social phobia. But there are many other spider phobias, snake phobia. And again, we all sometimes afraid of those creatures, or fear of dogs, fear of some open spaces, closed spaces. There are tons of phobias, and each of them has a convoluted name. Usually Latin name, but again, they all work on the same principle.
What about washing your hands too much? There are people who constantly, they're using hand sanitizers or overwashing their hands. It's a phobia of germs, right?
Well, yeah, it's germophobia, but that's usually a part of a different disorder. It's a part of obsessive-compulsive disorder. That's very typical phobia. Obsessive-compulsive disorders removed currently from anxiety disorders, which I actually have disagreement with that, because there are compulsive disorders that are not fear-based, but there are fear-based, and they behave exactly like phobia, and the same kind of principles of treatment help them. Those are also responsive to some serotonergic medications. And again, we frequently use them together with behavioral therapy.
What about generalized then? It sounds like it's such a broad category, and there must be quite a few people who fall into that. And the example that comes to mind for me is when women become moms. It seems like the worrying increases for them, because now they're caretakers and they have to watch out for someone else, and there's this and that. I would think that there's maybe a genetic component to that. I'm not sure. So if you can explain generalized and whether, and then the whole genetic component that may be tied back to.
Well, here is what's happening. I mean, normally every mom, when they become mom, they worry, you know. We're talking about excessive worries that interfere with function, worries when you, for example, don't let your child doing certain things that are normal for children, or not even allowing them to go to school because you're afraid that something is going to happen. And in generalized anxiety, it's usually very vague worries that occurs, and it could cover a lot of different things. For example, people could worry about other people in their family. A good example, you have a husband, not mom now, we're going to husband, who afraid that his wife will get into car accident and requires them to call every time. Well, of course, sometimes his wife is on the phone and forgets to call when she leaves the office, and she does not arrive on time. And suddenly he realizes she's supposed to be home. She's not at home. He starts calling her and interrupts maybe conversation with her friend. And she pick up. She's in the car, and she says, "You're disturbing my driving. Don't call me right now." And now he hangs up and feels, "Oh my God, I disturbed her driving." She confirms his worst fears. Then he calls her again, and she now doesn't answer, and he frantically starts calling. And then when he comes home, and they have the whole big fight about that. You see, we judge anxiety disorders by degree to which it interferes with people function. And most of the people can immediately determine that the person is really have excessive fears, and it's excessively interferes with their functioning. But some people just have garden variety anxiety, caused maybe by stress or by legitimate worry, or maybe by something that happened in their past, just like in post-traumatic stress disorder.
So it's about how much it interferes with the person's life. We're going to take a quick break and thank our underwriters and be back on how to address anxiety disorder with Dr. Bystritsky.
We know you, and we know you're out there listening. Support KXSF during our Low Power, High Ambitions fundraising drive by donating now at www.kxsf.fm. Every dollar goes straight into keeping SF Community Radio on air, providing music and programming you won't find anywhere else. Live, local, and totally San Francisco. Support KXSF 102.5 FM. Donate online at www.kxsf.fm. And thanks.
This is KXSF 102.5 FM, streaming worldwide at www.kxsf.fm. And you're tuned in to Spark with Kelly Marlowe, informing minds, inspiring ideas, igniting innovation. Let the conversation sink into your soul.
I was talking to Dr. Bystritsky about generalized anxiety disorder before the break. We were talking about how it's really tied to how much it disrupts one's life. So going back to that, you were saying so if it becomes a big disruptor, it becomes problematic. That's when you need to seek treatment. Is it the same treatment strategy for generalized as it is with social?
Yes, it is. But ABC is much more difficult to spot in generalized anxiety because almost everything is happening in the head. I gave you an example where some coping strategy happens outside of the head when the husband calling to the wife. But sometimes people just worry. Something triggers their worry. For example, they start to worry about their health or their partner or their husband or wife health. And nothing can reassure them. They say, no, they look sick or something like that. And that all happening within their head. They have a trigger which causes them to be physically anxious. It's very difficult to tolerate. Their belief is that their husband is, say, mortally ill, and nothing they could do. They bring them to the doctor. He is going to anoint. So the coping strategy is to bring them to the doctor, for example. But sometimes the doctor say everything is normal and finally refuses to see this patient. And the patient going back and worry becomes, or what's happening in their head becomes a coping strategy. And it almost like fuses coping strategy with trying to reassuring yourself.
So you reassure yourself by worrying more.
Right, because you feel if I don't worry about them and then they get sick, I will be guilty. So you see, sometimes this kind of faulty logic brings the anxiety and maintains anxiety. So the strategy is actually, again, educate them about what maintaining the anxiety, trying to identify this A, B's, and C's, and then we have much more control. We don't have much control over feeling because, yes, you could try relaxation, exercise, meditation. It takes time to learn how to do that. And some people so anxious that they never learn that or are unable to learn that in reasonable time. Beliefs are very difficult to challenge because you cannot kind of challenge something that you cannot see and that they do not share with you. And the third thing is kind of reassurance or action. It's a different thing. It's something under our choice and our control, but it's difficult without kind of experimentation, without trusting their physician or their psychologist to change those beliefs and make them not to go into this frenzy of worrying and trying to reassure themselves and then worrying again and trying to do some actions about that.
What about PTSD, though? It's pretty extreme, right? The veterans I've met and talked to, it's a very extreme form of anxiety. It's much more traumatic, and it's real.
Well, all of them are real. But in some other disorders, things that they worry about, for example, in panic attack, people worry about or have believed that they're going to die from this panic attack, but that never happens. In post-traumatic stress disorder, it's usually person experienced or witnessed something that is outside of normal human experience. They actually witness something or experience something where they were feeling that they're going to die, or somebody who is close to them, or somebody or massive number of people get terribly hurt, and person was close to them and was in a similar situation, then that get imprinted in their memories, and memories very frequently drive belief. The world starts to be dangerous, and they react to anything that reminds them. They have reminders of this episodes. And those reminders occur during the day, and sometimes they come in their dreams and start to seriously interfere with sleep. Sometimes people feel like the dangerous episode they re-experiencing there. It's a feeling, it's a flashback, we call it. It's almost like they again re-experiencing that, and sometimes they dissociate and not aware of the reality around them and react to that extremely. So it's a very complex disorder, and it usually has specific triggers that actually specific episode of danger that triggered that.
So what would someone with PTSD, how should he or she approach getting treatment?
Well, the treatment actually is on the same principles. Sometimes it's a little bit different from the other disorders that you do a lot of basically going over and over the episodes that happen, and you have to try to find the most vulnerable moment where they feel or felt that their life or body is disintegrating. And what works the best in behavioral therapy, it's prolonged exposure. Again, it works on the same principle, ABC principle. People have severe alarms, a reaction to those triggers. They have beliefs that they in danger at that time, and they avoid situations or do drastic things to defend themselves when they don't need to defend themselves.
But in
the
PTSD
frozen.
situation, they do actually physiologically feel, I mean, it is an extreme feeling for them, right? Because they've experienced it and it's imprinted.
Right, and actually this extreme physiological feeling during the episode may be one of the things that gets imprinted and re-experienced when people meet with a similar situation or situation that has remote even similarity. These extreme strong feelings and physiological response return. That's why sometimes people recommend to give some drugs, for example, like clonidine, that blocks this physiological reactivity in close proximity to the episode. Like for first responder, PTSD became more chronic. So people, you see, each episode you're re-experiencing become its almost like its own traumatic episode. You're experiencing, and then you say, "Oh, I cannot go in this alley. That was dangerous for me because these feelings overwhelmed me, and I could have been attacked again, or something like that." So even re-experiencing, creating secondary trauma in those people. So you do a lot of kind of talking to them, explanation. Again, we do sometimes explanation of this ABC. We try to reduce arousal, for example, at night. And there are specific medications like prozazine that could be given at night to reduce reactivity and nightmares. And it requires a complex treatment. Believe me, even for simple phobia, the treatment sometimes becomes extremely complex. It depends on severity of the reactivity, how ingrained people believe that they're in danger, and how flexible are people to change them. So sometimes treating simple disorder and complex disorders of anxiety becomes almost the same.
So it sounds like it's about how many different circuits get triggered at the same time?
We right now, besides medication now and behavioral strategies, we're also trying to understand what circuits involved in specific disorders in specific people, and people exploring right now combining circuits modifications with behavioral therapy.
Time for a short break, and we'll return more on anxiety disorder and how to treat it.
Come celebrate life on the edge of the Western world. Join KXSF 102.5 FM on Saturday, October 12th for the Ocean Beach Art and Music Festival at Noriega and 45th Avenue. Hosted by the Outer Noriega Merchants, this amazing community festival features local artists, craft for kids, beer and wine booths, food trucks, kids' activities, and loads of live music from a dozen bands on 2 stages, including the Sandys, Hot Mountain Dips, and the Reef Riders. KXSF will be there repping community radio with merch and kids' activities as well. That's the Ocean Beach Art and Music Festival at Noriega and 45th Avenue on Saturday, October 12th between 11 a.m. and 5 p.m. See you there!
This is KXSF 102.5 FM, streaming worldwide at www.kxsf.fm. And you're tuned in to Spark with Kelly Marlowe, informing minds, inspiring ideas, igniting innovation. Let the conversation sink into your soul.
Back to treating anxiety disorder with Dr. Bystritsky. So before we launch into the latest innovation that you're involved in, is there any genetic basis to anxiety?
Yeah, definitely. And different anxiety disorders have different genetic components. And there have been actually multiple studies that explored genetics. What we're coming down to, that those disorders do run in the families. Different disorders have different family percentage. Like, for example, OCD seems to be one of the disorders which runs in the family more significantly. So you could do population studies. In population studies, all anxiety disorders come related to depression and related to alcohol and drug abuse. And it's possibly because people very frequently cope with anxiety by starting to use alcohol or drugs, and then they get addicted to those, and then the addiction has a life of its own. But when you stop at any addictive drug, you have a huge rebound in anxiety that drives people. Sometimes it's part of the withdrawal, main part of the withdrawal that drives people sometimes to reuse the drug. So this comorbidity or co-occurrence happens in large family studies, and those three categories usually run in the same families.
So you have to be more aware if you're susceptible, or you could be more susceptible to...
Right, and some families just you have a feeling that they run diathesis of anxiety, and many members of the family are affected with the same disorder with different degrees. Some people are functional and some people are dysfunctional. As I said, that disorder may be, or diathesis may be present in different members of the family, but some of them learn to adapt to those. Some people use or thrive on anxiety, and they use that anxiety to enhance their performance, almost like scaring themselves into performance. And so it depends on how adaptive they are.
That would be novel, to be able to use anxiety to maximize or to enhance your performance.
Yeah, well, anxiety is... Well, the question is, if we did not need anxiety, I would say God or nature would eventually eliminate all the people with anxiety, right? But we need those. We need those circuits. We need those alarm circuits. Without them, we would be prey, right? So, for different carnivores. I think that anxiety sometimes supports survival.
Yes.
And again, it's in coping strategies. If coping strategies are adaptive, they are adaptive. For example, if you sitting in the audience and somebody walk in with a gun and you hide or you run, it's very adaptive, right?
So that brings me back to when you mentioned panic attacks and the difference between that and PTSD. It seems more common when people, let's say, have to do public speaking, or I guess it's probably similar to stage fright. In that case, it seems to be brought on by a certain cue, right? Environmental cue. Is it the same treatment if someone is feeling heart palpitation and it's increasing? Is there something you can do at that moment, or is that a treatment course that you need to be on in order to dial it down?
You can do something in the moment. You could reduce, for example, physiological sensation by giving people something like beta blockers. It's medication that stops arousal. You could sometimes, on certain occasions where a situation does not repeat itself very frequently, give some benzodiazepines, which with chronic use are not very good drugs because they have addictive properties, or you could become physically dependent on them. But in small doses, in some acute situations, they could be good. But let me again go back to this ABC theory. You could see how it could play out in say, panic disorder, where the trigger is your own sensation. In a way, panic attack is a fear. Panic attack is an event. Usually it's related to stress. But panic disorder occurs when people start being focused on this feeling within there, and they have believed that it's extremely dangerous, that they're going to die, or they have something seriously wrong with them. Panic attacks could occur in the situations that are previously caused by traumatic events. And in a way, some people who treat panic attack postulate them as post-traumatic stress towards a severe panic attack, which is extremely traumatic episode. Like people who have them for the first time, they know that it's not your garden variety anxiety. It's extreme. It's 100 times more pronounced than in any anxiety you normally experience. Some people say it's out of this world. I cannot control that. And of course, they just like in post-traumatic stress disorder, that is to external event, they incorporate that and in their memory and in their belief system. So treatment for that is to expose to these triggers and again stop people from inadequate coping, stop them from running away from those situations, gradually take more and more courageous move toward becoming free of this disorder, free of phobias associated with this disorder. It's a highly individualized treatment because no one has the same disorder. People have different circumstances, different life circumstances, family circumstances. It really needs to be approached what is the best for this particular person. But some overall strategy, of course, can help to some people.
Good to know. It sounds like it's more individualized than a generalized approach. Time for a quick break, and we'll be right back with a new innovation for treating brain disorders.
Join KXSF 102.5 FM at the Chapel on Tuesday, October 15th, as we present a double bill with singer-songwriters Jesse Mullen and Joseph Arthur.
Well, I'm up on 24th Street and I'm looking at a life, standing on the corner watching people passing by.
Mullen, the former D-Generation leadman, and Joseph Arthur of Fistful of Mercy and RNDM are on tour in support of their new albums Sunset Kids and Comeback World.
If you're downtown, keep it light. You might be out within the forest types.
The Chapel is located at 777 Valencia at 19th Street. The show starts at 8 p.m. and tickets are on sale at the Chapel website, thechapelsf.com. Hope to see you there.
You might be out within the forest types.
This is KXSF 102.5 FM, streaming worldwide at www.kxsf.fm. And you're tuned in to Spark with Kelly Marlowe, informing minds, inspiring ideas, igniting innovation. Let the conversation sink into your soul.
back to treating anxiety disorder with Dr. Bystritsky. He's also the founder of Brainsonix, a company that has created a device that's woken people out of coma. Can you tell me more about Brainsonix and the device that you are part of creating?
Well, I have to thank for that, actually, my work in anxiety disorders. Many years ago, I started imaging work in anxiety disorders, and I think I did one of the first studies where we stuck people into MRI and provoke anxiety and assessed function of MRI, or very quick MRI take, where you get almost like a movie of what's happening in the brain. So we were trying to find out what circuits involved. And the way we did that, we took panic patients or generalized anxiety patients, and we gave them to read their own scripts. And they started either experiencing anxiety, but sometimes they would not experience anxiety, and we would ask them why, and they say, I tried not to think about that. So I realized that people think about what they want to think about in the scanner, so I need to remove that. I need to stimulate their brain using something else. So I started looking for answers, and I came upon some old studies that were done on animal brain that was modified by focus ultrasound pulses. Ultrasound is a sound that we cannot hear, and it actually could penetrate the brain in certain carrying frequencies and affect very deep areas of the brain, all the way to midline, all the way to thalamus, where all the wiring from the brain comes together. So we developed this device in UCLA, and also I did some work as a visiting professor in Harvard Medical School, and flying back and forth. And finally, we have the device. This is right now research device. It has licenses from UCLA and Harvard, and we trying to stimulate deep areas of the brain in the scanner. And you could imagine that it's kind of dream researcher device. You could stimulate, and we found frequencies on animals where we could activate or inhibit different areas. And right now, we could start to look and stimulate different areas of the brain and see how other brain area are reacting. We're still trying to research and perfect this methodology, and so it's right now installed in 8 different universities, and we're starting to install it in different private centers. But our goal is to find out more how it works in the brain, and then apply it to the treatment. But the side effect of this discovery, we were permitted to experiment on coma patients by our Human Subject Protection Committee, mainly because those people may have nothing to lose, and we basically trying to find out if this device is safe. So the first person that we started to stimulate deep thalamic area woke up, and we were very surprised. And
there were no side effects.
And there was no side effect. The person basically.
So as I understand it, the reason you invented this device is because you felt patients were not responding to existing treatments very well?
Well, that was one thing, but also I wanted to study circuits, because basically right now we're giving people drugs, and they affect brain as a whole. We're trying to affect right now individual areas, deep circuits like anxiety circuits. For example, we're just starting at UCLA experiment suppressing amygdala, which is a key center in both PTSD and and generalized anxiety disorders and panic disorders. So I'm looking forward to more experiments. Right now, 2 VA systems got the device, like Palo Alto, Stanford VA, and Brown University VA have the device that they're going to apply to people with head injury and post-traumatic stress disorder. So I think as we're deploying the device and we're starting to study it in responsible way, our knowledge about how we could modify circuits will be expanded, and together with a new assessment of the circuits that we're developing in functional MRI, it will become the area is ripe right now for introducing new treatments for these disorders, and they would be more focal. They may suppress or eliminate disorders, or maybe they will make them more amenable to behavioral therapy.
So
right now, those people who do not respond to behavioral therapy or medication and do not respond to RTMS, going on to have electrodes inserted in their brain and modifying their illness this way. For example, there is approved device for insertion of electrodes in the brain, and at UCLA we have this program, and we work with the Department of Neurosurgery, and I'm in charge of this program. And but those are drastic measures reserved for very, very sick patients. And I hope with our device, we will be treating, say, OCD patients that we're using electrodes right now. 2 of our investigators, one in Baylor, one in Harvard right now, won breakthrough award in OCD, and they're going to start experiments using Brainsonix device treating obsessive compulsive disorder, and I hope the results will be spectacular.
So
but
the device has the ability to either activate circuits in coma patients or suppress circuits in anxiety disorder. So it has the ability to do both.
Its ability to do both, because we need to, since we could move the device and stimulate or activate or inhibit different areas, this gives us an opportunity to try different locations, and in different patients they may be different. We have very dynamic brain. So what my hope, how the treatment of mental disease will look like, that we will be assessing them with specific tests in a functional MRI, identifying which circuits exhibit weakness, correlate that with human behavior, and then administer modifying techniques to modify those circuits to affect the best possible outcome. And then people, if they have residual symptoms, will be going for still behavior modification, because they need to unlearn old coping strategies, which very frequently in treatment-resistant patients become habits, and they need to learn new positive.
So everything still comes down to learning.
Right. So, and maybe we would be able to enhance learning by applying our device to memory area. So it increase access to them. So it's multiple applications. We're just at the beginning of extremely interesting and fruitful journey.
This is very exciting. I can't wait till you make me into a superwoman with that device. Then I won't forget anything. So back to
I'll put you in the queue.
Yeah. I can't wait. Back to our discussion about anxiety disorder. What would be the call to action for someone who is feeling highly anxious? What would be the steps, the top 3 or 4 steps that you recommend?
Well, the first thing I would recommend is if it interferes in your life, and does not go away with some of the methods that, like herbal medications or some relaxation exercise, and so on and so on. If it doesn't go away with that, find a professional help. The professional help is available. There is an organization, Anxiety Disorders Association, Anxiety Depression Disorders Association of America, ADAA.org. There is also anxiety.org. I believe you would need to get evaluation and then apply the treatment they recommend. And again, the menu of treatments would be medication, behavioral therapy, combination of thereof, and then do behavioral therapy, which is not immediate thing. It takes a bit to unlearn poor coping strategies, learning new strategies. Somebody has to teach you ABC concept of anxiety so that you know how your symptoms interrupt. And anxiety.org, we actually have a way how you could monitor those. And then be patient. This disorder usually requires patience and optimism. Majority of anxiety disorders are very treatable. They go away. But you need to apply a different treatment. If you become treatment resistant, try to look for specialty programs or specialists in that disorder, because they may find out what went wrong with the previous treatment, or what is needed to be done as the next set of strategies. Let's say that there are a lot of treatments. You just need to find what works for you.
Okay, so I love to always end with a transformation story using these steps that you just recommended. So could you tell us about a patient that you work with and how these steps were applied and how it worked for him or her?
Something that comes to mind, for example, a story of this person, a writer, who had social anxiety in combination with panic, and he was completely homebound because he was retrieving from social interaction. And finally, anxiety disorders does not give up. You need to do coping strategies that are inadequate. It's going to get you more sick. So this person had actually fear of social interactions and going into social places and for fear of panic attacks. And sometimes it was accompanied by diarrhea. So he was giving first presentations, and then because he was writing plays and movies, he could retreat, and finally it's a sad story. He was homebound. So he was slowly explained what needed to be done. Slowly we exposed him his internal sensations of anxiety and panic. We slowly exposed him to external situation more and more, rehearsing it several times, because you really need to relearn. You already learned how not to go there, and it's not a simple desensitization. You have to new adequate coping strategies. But eventually he could come out, did presentation, started to become even more successful because now he could sell his stories. That story was positive. He was fully functional.
Well, thank you for this transformation story. And thank you for joining me on Spark today, Dr. Bystritsky.
Thank you very much.